Hi, my name is Teresa Grothis, and this evening I'd like to talk to you about using high-dose insulin to treat beta blocker overdose and calcium channel blocker overdose. And so today's lecture or class is aimed at educating critical care nurses in the ICU and ER settings. This plan of care usually starts in the ER and then, of course, continues on to the ICU. So I am speaking to registered nurses who are already practicing nursing in both the ER and the ICUs. Today's objectives are going to be to overview calcium channel blockers and how they work in the body, an overview of beta blockers, how they work in the body, and then how high-dose insulin is used to treat the overdoses and in hopes of keeping the patient from going into cardiogenic shock. The way we're going to measure those outcomes is that there will be a test at the end of the lecture, and that test will be of 10 questions, and it'll be taken individually, and an 80 or higher has to be obtained for credit in today's class. And the hospitals are requiring that this class be taken by all of their ICU and ER nurses so that they'll understand how to treat these overdoses. I am so sorry. On a side note, I am overcoming bronchitis. I'm going to try very much not to cough too much. So we've all had patients who've come in and who've taken beta blockers and calcium channel blockers. Most of the time, our patients take these medications to lower their heart rate or for an irregular heart rate, and of course to lower their blood pressure. Calcium channel blockers and beta blockers are extremely common medications, and they're also the number one cause for patients to come into the hospital in cardiogenic shock for poisoning. Now, this can happen to children who get into grandma's medication, grandma thinking her medication is her ibuprofen, so there can be accidental overdoses. But in a lot of times we see that these are patients that have, for one reason or another, have decided that they just have had enough, and they just literally take their entire bottle of medication. So the side effects of these medications are that they affect both the heart's conductivity and the inotrope as well as the vascular system. But both medications also play a role in how the body releases and uses insulin. And that's where the high-dose insulin comes into play. So with your beta blockers, you have your B1, your B2, and your B3s that are affected by this medication. And so by doing this, the B1s are regulated so that the myocardial tissues, the contraction rate doesn't have to be as forceful. The B2 regulates so that the smooth muscles are dilated more and the vascular system relaxes. And then the B3s, those affect your cardiac inotrope, or the forcefulness in the contraction. And so we take these beta blockers in the use of treatment for irregular heartbeats, like metoprolol, angina, and then you also treat hypertension with it. One of the other effects of beta blockers is they block the release of insulin from the pancreas. They have an effect that just sends signals to the nervous system that inhibit the body to actually recognize hypoglycemia. And so the body doesn't release insulin until it's needed. And so beta blockers, especially in large dosages, block the body's ability to recognize that it needs to release the insulin. So in calcium channel blockers, they do exactly what their name says, very easy to remember. They block the calcium from going in and out of the calcium channels. And by doing that, they have a profound effect on the myocardial cells. They smooth out the muscles of the heart, and then they affect the B islets of the pancreas. The B islets of the pancreas don't secrete the insulin like they're supposed to. So you take, normally we take this medication so that it will prevent the calcium from entering into the cell during phase 2 of the action potential. And this reduces the afterload and then reduces the systemic blood pressure. So when taken as directed, wonderful medications. When taken in large dosages, can become very lethal. And you have your hypotension and you have your bradycardia, your things you're looking for. But then the one thing that is overlooked sometimes is the fact that we can pump fluid in we can start vasopressors, we can do all sorts of things to try to get your heartbeat up and your blood pressure up. But if your body is not using any insulin, it is not secreting any insulin, you're going to become hyperglycemic, and then you're going to become very metabolic acidotic extremely quickly. And so the insulin actually helps treat some of the side effects on the myocardial tissue as well. So it's not just treating the low insulin, it also treats the conductivity of the heart and improves the inotrope of the heart itself. I'm so sorry. So the high-dose insulin, it becomes a very scary thing for nurses, especially when if they're unfamiliar with what they're doing or why they're doing it. We give 0.1 units per kilogram per hour of insulin on an insulin drip for our DKA patients all the time. Most of us still get a little nervous when we start hanging insulin on patients. We've got to check the blood sugar. We want to make sure that we don't allow them to be hypoglycemic or hypokalemic, and we watch those labs, and we have to be very vigilant on trying to make sure that we close the gap and do everything we need to do for DKA. Well, these overdose patients are not in DKA, but they are in a similar situation where we've got to intervene and allow the body to have this insulin to do what it needs to do. So we actually start the insulin at 1 unit per kilogram per hour, and you can titrate all the way up to 10 units per kilogram per hour. So most of our pumps in the hospital, if you went to put your insulin drip on and you put 10 units per, things would go crazy. And you can see where if you're not aware of what you're doing or why you're doing it, it would be a very scary order for a nurse as well. So these patients come in. We need to protect their airway. We need to get IVs on them. We need to get initial labs. If we're lucky, they're coming in by EMS. They've already done our detective work on scene. They know which medications they think the patient may have overdosed on. There's pill bottles. There's family members, that kind of thing. These patients will be very diaphoretic, they'll be very pale, they'll be vomiting, and they will have a super low blood pressure and a super low heart rate, which will just continue to drop in front of you. Just you can watch it happen. So they're hypovolemic, then onto the cardiogenic shock. So the muscles and the heart are just getting less and less active. They're doing less and less work. They're not doing much of anything because all of that medicine is telling them to stop. And so the large dose insulin, not only does it push the insulin into the blood to allow the body to use the glucose and to break down the glucose the way it's supposed to, and carbohydrates the way they're supposed to, so that the body can have the energy it needs to function. Because at this point, the heart is starting to stop beating. Everything is starting to drop. And the whole energy cycle, the whole Krebs cycle, it can't work. You can't get your energy going at all because you don't have the insulin to break down the glucose to get the glucose to do its job. The glucose can't get pulled into the tissue to do any of its job to give the body the energy it needs. It just floats around. So the high-dose insulin is started as quickly as possible. It started with a bolus dose of 1 unit per kilogram per hour, and then the drip is started. Another thing, beta blockers, especially propranolol, can cross the blood-brain barrier and can cause the patient to be extremely lethargic. Can actually cause a sedation. So super important that if you think that patient's CNS is becoming an issue, that we secure that airway as quickly as possible. Most doctors are going to intubate anyway, just because you don't want to wait and see what happens. These patients are kept on this insulin drip for quite some time, sometimes well over 24 hours. It's not uncommon for the adult patient to be on the drip for about 24 hours and to use 1,000 and 500 units of insulin within that period. So you've got to call your pharmacy, got to let them know what you're treating. Talk amongst your peers, talk amongst your coworkers, the doctors. Get to be familiar with how to treat these overdoses. So when we see them, we can get on them, we can treat them, and we can give them some chance at trying to overcome this. These patients will sometimes need ECMO, sometimes need emergency dialysis. But study after study after study has shown that the high-dose insulin is the standard of care. And we just need to be aware of it, and we need to know why we're doing it and not be afraid to do it. And so I thank you for your time, and we'll take the test, and hopefully everybody will do very well. Most people, the questions they have at the end are lab tests. So you're going to test your glucose every 20 minutes once you start the drip initially for the first hour. Then it'll be hourly thereafter, and you'll be testing your potassium every hour as well. These patients don't usually need intervention on potassium or glucose for several hours into treatment. But once they do, then we'll look at the D5, D10, and then the potassium replacement, similar to that of a DKA patient. So I hope I educated you. I hope I taught you something new. And I hope I've answered any of your questions. And thank you for your time.